that are associated with suicide ideation. However, for some women, in very rare cases, some women do commit suicide. We understand that. There have been 2 deaths related to suicide between 2009 and 2011. But women wishing to take their life in pregnancy, it's rare. It can be assessed by our psychiatric friends. It involves women to be listened to, believed, and to be treated in the totality of the condition. Nobody suggests that suicide, the termination of pregnancy, is a cure for that, but it may be appropriate in certain very rare circumstances as part of a general treatment plan. I think the next issue that has been brought up is this whole idea of probability, Senator Creelon, on probability versus certainty. Doctors always deal with probability. We rarely have the certainty that death is inevitable until it's happened. So we deal all the time with probability, and what we are asking for is to have the flexibility and the legal protection to make sound, sensible medical decisions based on medical probability. We don't have the luxury of certainty of being able to look into the future and say, yes, that woman will definitely die. We don't have that certainty, but we need to have flexibility where we believe that there really is a risk that a woman might die. And we do come across women who have serious underlying medical disorders who do die. We see this in the triennial report into deaths, and we have those women whom we treat who wish to continue their pregnancy, in whom the treatment during pregnancy is terribly challenging. We need flexibility and we need legal protection. This is about saving life. Where possible, society may be reassured that our aim is to preserve life where possible. Again, in terms of the various timeframes, I think this relates to emergencies. In an emergency case where a woman is definitely dying, there's no hesitation. But obviously, in most units in the country, we have a number of consultant obstetricians. For example, in a hospital like the National Maternity Hospital, we always have a consultant obstetrician who is first on call. They are on the specialist register. There is always a second obstetrician in reserve on call for those difficult cases when we are very challenged. So there is generally an adequate quorum, I believe, in terms of whether the need for termination of pregnancy arises in an emergency or an acute situation. Where we have a bit more time, doctors work in teams. We very much work in a multidisciplinary fashion, and when we are making important decisions like this, what we will do is gather all the available information to us from within our own field and, if required, from other specialist fields, and we will put that information together and we'll make the best decision we can, but we will make that in a multidisciplinary fashion. Nobody is suggesting that doctors would ever make such decisions in isolation, but this can be done in an expeditious manner, I believe. Finally, in terms of the sections 58 and 59, they remain in force. Abortion in Ireland is a criminal offence which is punishable by penal servitude. That law stands today, and I need to know that I will not go to jail if, in good faith, I believe it is the right thing to save a woman's life, to terminate her pregnancy. I want to know that I will not go to jail, and I want to know, by the way, that she will not go to jail. It doesn't matter whether or not anybody has been sent to jail before. That is not an issue. The point is there is a significant risk that I could be sent to jail, or I believe and perceive there to be a significant risk that I might go to jail. And I think that is something that I want clarified or further guidance in. Suicide, again, coming back to suicide, Deputy McGrath, suicide is extremely rare in pregnancy. A woman's wish to take her own life during pregnancy is terribly rare. And as I've said, I'm not for one moment suggesting that termination of pregnancy is a cure for suicide, but perhaps we must allow for the fact that in certain cases some women will kill themselves during pregnancy, and we must have a way of assessing that, and we must treat these people with compassion and with expert care. Finally, I think we should be very careful of absolute statements such as the so-called Dublin Declaration, which, by the way, I don't particularly recognise. I think it is not correct to say there is never an indication for termination of pregnancy, and I think we need to be very careful about absolute statements. We are talking about real life, and in real life there are rarely absolutes. With regard to mental health, as Dr. Smith has pointed out, about 10 to 15% of women will be affected by a variety of disorders of mental health. In the vast majority of these cases, these women can be very successfully treated during pregnancy. They don't have to stop taking antidepressants. They can receive their expert care and treatment during pregnancy. For many of these women, we have no concern that they will kill themselves. That is not an issue. They require treatment for their disease, but we don't have a concern that these women will kill themselves. We do have excellent perinatal psychiatrists, and yes, I appreciate we only have 3, but we are not talking about dealing with all issues pertaining to mental health. We are talking about the very tiny number of women who wish to kill themselves during pregnancy. That is not, it is a tiny number of women. I believe we have the capacity to do that, but that is obviously a question that must be put to the expert psychiatrists who will address you later today. But it must be stressed, we are talking about a small number of women. Very interesting question about the substantial risk to life. You know, how is that assessed? And Deputy O'Quillan, I understand as well, you asked me about precision. How do we develop a tool with such precision that we can identify those women who will die either because of medical disease or who might take their lives? Well, of course, you're never going to be able to come up with perfect legislation or regulation. What we're asking for is for the lawyers to draft a legislation that allows us some flexibility. It will be impossible, for example, to write a list of disorders which might qualify. That's not really what I'm suggesting. I believe that 2 expert medical doctors or additional doctors in the variety of specialties that might be required, for example, cardiology, psychiatry, whatever, 2 obstetricians who are experts in the field, who are able to gain all the information they need, obtain advice from their colleagues. I believe that 2 consultant obstetricians are able to determine when there is a significant risk to life in a pregnant patient. And I believe that they should have the ability and the flexibility to identify those women and to treat those women appropriately without fear of prosecution. But it is doctors, it's a medical decision whether or not someone is likely to die or not. This is a medical decision based on medical fact, and doctors must be able to make these decisions if they are to do their job properly and preserve life. Thank you.
Thank you, Dr. Coulter and Dr. McCaffrey.
Thank you. Again, I'd like to echo all of the comments that Dr. Mahony has answered there. How do we impact? What is the impact of legislation if we do bring in legislation which allows termination of pregnancy in this country? What will the impact be on our services? I don't think we know the answer to that question. I would agree that that risk of death from suicide is extraordinarily rare. However, we don't know the number of people who go from Ireland to the UK seeking termination of pregnancy in that jurisdiction, and we don't know what numbers might then come to us and not go to the UK. So I think we don't know the answer to that. There are people who will seek termination of pregnancy because of rape, incest, because they have babies with lethal congenital abnormalities. Some of those women will come to us and say they have significant mental health issues. Those women will then need to be assessed by the psychiatric services and the obstetric services in this country. That's not a function that we're actually doing at the moment. So I think there will be an impact, but we don't know how big or small it's going to be. In terms of conscientious objection, I cannot think of any circumstances where any health professional where a mother's life is imminently at risk would say that they would not be involved in her care. So I can't see that would be an issue if if her life is genuinely at risk. I think in terms of the legislation, I think it needs to have within it flexibility to allow the medical profession to make appropriate decisions. I think we need to trust our medical practitioners to make the appropriate decisions. I think the regulation that's put in place has to ensure that there's an appropriate number of suitably qualified doctors who make the decisions, and they need to be protected by legislation. Is termination of pregnancy, is it ever necessary? I would say yes. In our hospital last year, we had 6 situations where I can absolutely tell you for sure that if intervention had not been made, then that mother, if she hadn't died very soon after the event, then she would have died subsequently. So I would say yes, those situations do happen, and in our hospital they happened 6 times in the last year. If I haven't answered all of the questions, then please come back to me.
Another members, okay. Dr. McCaffrey, do you want to just answer any of the questions?
Okay. To Deputy Kelleher's question about should lists be published, I would have huge concerns with that publishing list, because doctors are going to manage patients on a case-by-case basis. Every case will be different. There's always a risk that if you publish lists of people who will do A, B and C, that you will actually discriminate against people. For example, in the UK, you're not allowed to ask at an interview if someone will do a termination of pregnancy or not. Different scenario. But the important thing is that no practitioner will ever allow a woman to die because they won't do something. We will be there to save lives, and we do it all the time. Deputy O'Quailon asked about the legislation, had it ever impacted? For me, no, it's never impacted. The life of the mother has always come first. And yes, pregnancies have been have ended earlier than anticipated in my practice and in other people's practice, because the life of the mother was at risk. Deputy Conway asked about cancer. I would feel terrible even talking about cancer with Senator Crown in the room, but I've had patients who have had cancer and who've had appropriate treatment, surgical treatment in pregnancy, who've gone on then to have their chemotherapy at a later stage in pregnancy, have their radiotherapy after the pregnancy is completed. Again, each case is a case-by-case basis. It's about multidisciplinary teamwork, it's about consultation, communication, and dealing with the mother's life is what's most important. And yes, there may be situations where a baby will be delivered early because the mother's life needs further treatment, but more and more cancer services and the evidence is showing that you can coast to a point in the pregnancy where the baby is viable, and that's obviously what people are always aiming for. In terms of the suicide issue, I suppose we need to become very focused on the fact that there are other treatments for suicide, and if a male patient pitched up in A&E tonight and said he wanted to kill himself, there would be treatments, there would be medical treatments, drugs, therapies, and then they would be reviewed in a couple of weeks, because that's the first line treatment. But yes, then cases are reviewed after a couple of weeks. I think they're the questions mainly that you asked.
Okay, we have 8 speakers now who've indicated in this slot, and we'll start finished at 20 past, so if members could be brief in their questions, please, to allow for response. Deputies Naughton, Dowds and Healy in that order, please.
Thank you, Chairman. Can I thank each of the speakers for their presentations. First of all, can I thank Dr. Coulter-Smith for his statistics, which I think give a context to what we're talking about. And can I ask you, you're saying that in the Rotunda there are 5 to 6 in the last 12-month period, 5 to 6 terminations. Is it likely that there will be a higher rate in the likes of the Rotunda because it is a tertiary referral hospital? Or have you any indication of the type of numbers that we're talking about on an annual basis? Secondly, if I could ask you, you made the point that about 1.5 million women present with suicidal tendencies during pregnancy, based on UK figures. Has there been any research in relation to where a termination takes place, whether it has increased or reduced the suicidal tendency, or does act as a cure to that suicidal tendency? Is there any research in relation to that whatsoever? Thirdly then, you make the point that there's a need for a referral pathway to be put in place for decision-making in cases of smaller maternity hospitals. And I want to thank Mary McCarthy and Dr. John Monaghan for being here from 2 of the smaller facilities. Dr. Monaghan, of course, is from Portiuncula in Ballinasloe. And if I can refer them back to the evidence that we received earlier from the Medical Council, who have said that there shouldn't be specific provision for emergencies. Yet you, Dr. McCarthy, in your own presentation, have broke your presentation into 3 categories where you specifically talk about emergency situations and where you make the point that in relation to the second opinion, that it shouldn't be a physical signatory in an emergency situation. So can you comment on what the Medical Council have given to us here? And I'd like the view of Dr. Monaghan as well in relation to that, as to, you know, the view of the Medical Council. And could you also comment, there is a genuine fear out there among people serviced by the smaller maternity hospitals that this could in some way be constructed in such a way to reduce the capacity or to see the amalgamation of some of the smaller maternity hospitals into the more regional centres.
Thank you, Deputy. Deputy Dowds.
Thank you, Chair, and thank you to our expert witnesses. One of the things that comes across to me is the lack of certainty as to, you know, whether a woman's life is absolutely at risk, and I very much feel for that because my wife had very difficult pregnancies when she was at that stage of her life. But my question then really relates to this: if we are to legislate adequately, is it possible to do so without going back and removing the article in our Constitution which puts great restrictions on abortion? Thank you.
Thank you, Deputy. Deputy Seamus Healy.
Here, look, I'd just like to thank the witnesses for their submissions. I think they've been very informative and indeed very helpful, certainly to me. Just in relation to a number of issues, you know, the probability of real and substantial risk to the life of the mother. Could I just ask for some clarification in relation to that? I mean, we all understand, say, an immediate situation, but would there be a situation, obviously, where the life of the mother might be at serious risk, you know, down the road in 6 months, 12 months, 2 years? Also, the question of local units and emergency has been raised, was raised earlier with the Medical Council and was probably not dealt with effectively in my view. Now, could I just ask, particularly Dr. McCaffrey, her submission suggests that the local units would only deal with emergencies, that the other, any other issues would be dealt with in tertiary centres, say in Dublin, Cork or Galway. You know, is that what Dr. McCaffrey is suggesting? And in relation to emergencies, the Medical Council suggested that there was no particular procedures, special procedures necessary in relation to this. I'm just wondering what the views would be on that. And finally, in relation to conscientious objections, the report, the expert report suggested that while obviously there is necessity for conscientious objection, that it's not always absolute. And do I take it from what people have said that that refers to specifically cases of emergencies? Thank you.
Thank you. I take Deputy Doherty now as well, and Senator Crone.
Sorry, thank you. First of all, thank you obviously for coming in this morning and your presentations. Can I ask, just against the backdrop of you having described, you know, the superb level of medical care and intervention that's currently on offer in Ireland, and I think that's a given. You said, and particularly Dr. Mahony, that there was something that was stopping you giving today, making sound medical judgments and decisions relating to the medical care and the interventions of women. Can I ask you what that something is? Given the clarity of the medical guidelines that were discussed here earlier on this morning, what specifically that something is? And also, generally to all of our guests this morning, can I ask if you know how many terminations or early deliveries have actually occurred in your hospitals arising from the threat of suicide as a risk to the life of a woman since the X case judgment, please? Thank you.
Thank you. Senator Crone.
Thank you. We've already established that when I stand up, the microphone doesn't work, so please don't see any disrespect if I ask my questions from a sitting position. I'd first of all like to thank you all, and I'd not only like to thank you, but I'd like to commend you. You've all made me a little prouder to be a doctor today. You had great clarity, honesty, and conviction in what you've said, and I think that's critically important in trying to address this issue. Again, I'm sorry, we must seem like we're perseverating on this. I'm guessing from the arithmetic that Dr. Coulter-Smith advanced and extrapolating from a disproportionately large number of complex pregnancies going to the referral centres in Dublin. I'm guessing that nationally we probably have something like the order of magnitude of 30 to 40 terminations of pregnancy which are necessary and which are now carried out to save the life of the mother. Please correct me if I'm wrong on that. That would appear to...
Yeah, to finish now.
And I'd like to ask you all to also just to clarify for me, is it, and please, I'm not hinting at any specific case or asking anyone to, in any sense, put themselves in a position where they may appear to be standing in judgment on any of their colleagues in any case over the years. Is it any of your opinions that there have been maternal deaths in this country which were needless, which were unnecessary, and which would have been specifically prevented had there been greater clarity in the legal framework, that a termination of pregnancy for a life-saving indication was not offered because the doctor, perhaps in good faith, felt that he or she was not adequately legally covered or might have been breaking the law if they performed it? I'd also ask you just to touch on one other issue which is being mentioned and has been mentioned in the other House of Parliament here, and that's the distinction between a termination which is necessary to specifically save the life of the mother as opposed to for the health of the mother, because that is being advanced. And my own sense, and again I may be being medically naive here, is that there probably are not conditions which threaten your health, but which to some even small extent threaten your life. And as such, that's probably not a huge issue. And I'd also like to just ask you to clarify, and I'm sorry, we really will not be going into medical details here. Is it ever necessary in performing a life-saving termination of pregnancy to specifically kill the fetus in utero? Or can the pregnancy be delivered to give the life-saving indication which the woman needs? Because I know this is something else that some others have raised in objection. And also just perhaps if Dr. McCaffrey could just clarify something which I think you said in good faith earlier about the hospital in the UK where nearly the entire cohort of anesthesiologists refused to anaesthetize a termination patient. I'm sure you meant not in the case of an emergency. You meant in a situation where there was. Okay, thank you very much.
Okay. Maybe you want to start this time, maybe?
If it's okay, I think it's probably better if I sit. It's easier. It's closer to the microphone.
Here.
I think the number of terminations that we would perform in the hospital last year was 6. It's my belief that the number would be roughly similar, but I think that the incidence has risen in recent years. I think the reason for that is possibly due to the increasing age of the pregnant population, the increasing complexity of illness that we face, and also the rise in obesity levels. I think they've all come together to increase the risk for our population. In terms of risk of suicide, when I said 1 in 500,000, that is the if you look at the UK figures, that is the incidence of suicide in that population, not the incidence of people coming forward with suicidal ideation, which would be a lot higher than that. I think in terms of certainty of risk, I think it's a hugely difficult area. There are many grey areas, and I think we need to trust in our medical practitioners. We have a fantastic quality of health professional working within our health service. The problem is getting in to see them, not when you get to see them. And I think we have to trust in our excellent doctors and trust in the judgment of those individuals and protect them in making those decisions. Do we need to review or change or take the existing laws off the statute books? I'm not a lawyer, so I think I would leave that question to the lawyers. have we ever had to perform a termination of pregnancy because of risk of suicide? Not in my experience. Senator Cran asked the question, if we extrapolate the numbers from the Rotunda nationally, I think he's in the right ballpark. I think the tertiary referral centres would probably see more of these complicated cases. So I would have thought that the figure nationally is probably 20 to 30, but you're in the right region. Have there been any needless maternal deaths because people felt that they couldn't or wouldn't act? I'm not aware of any such situation. And I think the last question was, are there situations where a fetus needs to be killed in utero rather than delivered? I think in most situations it's possible to deliver the baby or deliver the fetus without actually killing the baby in situ, I think, in most situations.
Okay, thank you. Dr. McCaffrey?
I think I need to stand. In terms of have there been any maternal deaths because of needless obstetric intervention, I'm not aware of any either in any situation. I'm not aware of any death as a result of suicide because a termination was declined to somebody. In terms of Deputy Healy's questions related really to the smaller units, I think, you know, my presentation I thought made it clear that the more severe medical cases like cardiac disease, really bad heart disease, we would be sending those out to be managed by a multidisciplinary team in a different unit, and it would almost always be Dublin, I suppose. The obstetric emergencies we manage by and large in smaller units, and the 3-man units vary in size as well, because we must remember Waterford delivers 3,500 with 3 consultants, which is admirable, so they wouldn't really be a smaller unit, but it depends on the skill mix, it depends on who you have on duty on the day, it depends if there's an intensive care bed available to you on the day, so there's a lot of parameters. That's why the expertise of the clinician who's standing on the end of the bed has to be acknowledged, and back to Rhona's point, has to be protected in law, that they are making the right decision for that patient at that moment in time. And I think we have to look at the track record of smaller hospitals in terms of maternal death. I don't tempt fate by talking about it, but we have a very good track record in how we manage our patients and sending out appropriate patients and managing patients locally. In terms of the second signatory, and I know that, you know, the Medical Council have said it isn't necessarily necessary. I think it's always good practice to discuss very complex cases with a second person. And bear in mind, I talked about locum staff as well. They might be just breezing into the hospital for a week or two. A lot more things go wrong when you have locum staff on duty. And one of the proposals, because my time ran out, that I didn't get to talk about, was that there could be a place for looking at having a panel of experts nationally. Say, for example, the 3 masters. If they're not on duty, they usually have a deputy, the clinical director and CUMH or whatever, that we would have resources to fall back on if you needed to discuss a complex case and come to a conclusion. And you would hope it would never happen, but as someone raised the point, what if the second colleague in your hospital didn't actually agree with the decision you're making? Then you would need to take it to a higher level to get the opinion of Sam, Rhona, or an equivalent person. So I think, you know, we have to look at strategies to deal with these things. But in general, in the smaller units, our track record has always been very good in terms of maternal morbidity.
Thank you. Dr. Mahony?
Thank you very much. So just coming again back to the idea of suicide, yes, the instance of suicide is extremely rare. As Dr. Coulter-Smith points out, this is not the same thing as the instance of intent to commit suicide or suicide ideation. It's actually very difficult for anyone to identify what is the instance of suicide, because very often these cases are returned in the coroner's court as open verdicts. So I don't believe we have accurate data in that regard, except that we can say with some certainty that it's extremely rare. We do also know that some women will take themselves to a different jurisdiction and will choose to terminate their pregnancy. So it is extremely difficult to assess what is the true instance of suicide, and indeed suicide ideation and suicide intent. Again, coming back to the whole issue surrounding lack of certainty, there is a lack of certainty. There will always be a lack of certainty because we deal with medical probability. And again, I will say that the assessment of the risk to life in the context of medical disorder is a medical decision, and doctors must be trusted, as Dr. Coulter-Smith says, to make these decisions. This is our area of expertise. This is what we do. This is our job. What we're asking for is that we are legally protected in doing this job. You asked me, is there anything specific that's in the way that I feel is a block? I do take issue with sections 58 and 59 of the person against the Offences Against the Person Act. Excuse me. I do take issue with that. I think that is a problematic area, and I do think that needs to be addressed. And in fact, the European Court agrees with me in this regard. In terms of extrapolating cases, you know, how many extra cases of termination of pregnancy do we anticipate? The numbers are very tiny. In my hospital last year, we had 3 cases where we had to intervene prior to fetal viability because of our concern that a woman would die. There's a tiny number of cases, I believe 1340 actually to be an overestimate. I believe the figure is much more likely to be nationally somewhere between 10 and 20. In fact, these numbers are actually very tiny. We never kill a fetus. That is not what we're about. Occasionally, it is required that we deliver a pregnancy before the baby is viable, before the baby is capable of surviving in our neonatal intensive care unit. And I would like to reiterate that when there is any chance, any possibility at all that we are able to preserve the life of the baby, we will do so. And we are able to do so from very low gestations, from 23 weeks on, and in those cases be very certain that we will make every effort to preserve life. In other cases, we require to terminate a pregnancy as part of a treatment of a medical condition because we feel a woman will die. That is not killing the baby, that is simply delivering the baby before it is viable, and there is a difference. It is always our wish to preserve life, and society should be very reassured of that. One point I'd like to address that Dr. Coulter-Smith brought up is the changing demographic. We have older women now becoming pregnant. They have different disorders. They're more likely to have coincidental medical disorders, and therefore it is very important that doctors once again have the flexibility to do their duty with legal protection. Thank you.
Thank you. Okay. Our next speaker is Deputy Catherine Byrne.
I want to thank both or 3 of you for being here this morning. I think I hear you loud and clear, Doctor. What you're saying is, let me do my job, but while I'm doing it, let me be protected as well. And I think that's come across very clear in all of that you said this morning. I suppose as a mother of 5 children and who have had in the past my own misfortunes of having miscarriages, it is very difficult with the great joy that when you're told you're pregnant and then things happen and things don't go the way you would like them. But I think what happens there is, what steps in there is the honesty and the trust that you have with your GP or your local doctor or the doctor in the maternity hospital. I think that's very important for all of us to hear that again clarified this morning about life is so important to us all. I just want to refer to something I raised this morning with the Medical Council around section 21 about abortion, and just around this. I'll just read some of it because it's long, and it's 21.4, and it says, due to extreme immaturity of the baby, there may be little or no hope of the baby surviving. In these exceptional circumstances, it may be necessary to intervene to terminate the pregnancy to protect the life of the mother while making every effort to preserve the life of the baby, and you've said that yourself. But in saying that, I don't know for myself, maybe for other colleagues, the emails and the devastation that we've read through lots of emails and letters that we've got about people still having to leave this country and having terminations of their pregnancies, and a lot of them due to this extreme immaturity of the pregnancy of the baby, and having to bring back the dead baby in a box in the boot of the car, or have the baby cremated away and bring it home, and just a whole impact of that on people's lives is devastating. But according to this, according to what I've read to you, you can correct me if I'm wrong, does this not mean that we shouldn't be sending away those people? When we know, when you know as a professional, that these people, the circumstances that they're carrying their baby are extremely, that they're not going to live after birth. Can we not help these people? Because there's a lot of young women out here and older women now experiencing these difficulties. I know in many of the emails and letters that I've received, the harrowing stories of people having to go away when they've been told by the doctors here in hospitals that their babies are not going to live. So maybe you could clarify that.
Thank you, Deputy. Deputy Mary Mitchell-O'Connor.
Thank you, and thank you very much for your presentations. Can I just go back to the presentation this morning from the Medical Council? And I just can't seem to get it. What they said to us very explicitly this morning was that special procedures do not need to be developed for emergency situations. And I'd like you to comment, maybe to say, are you in agreement or not with the Medical Council? Because we're here trying to, you know, accept information and work on it. And the other then, I just want to ask you, you know, you talked about that you need clarity. And I'd like to know what deficiencies, and I know you've kind of said it globally, but what exact deficiencies are in the medical guidelines there at the moment, please? And the third point or question I'd like to raise, and it reverts back to Deputy Ciara Conway's, the ethos of the hospital. Does that impact on different hospitals and how women are treated in hospitals when they're pregnant? Thank you.
Thank you, Deputy. Deputy Peter Fitzpatrick.
Just like to ask two questions. Are pregnant women getting the treatment they are entitled to when there is a real and substantial risk to their life as opposed to their health? And then the last question I'm going to ask is about giving legal clarity to doctors and patients about when it is permissible to terminate a pregnancy when a woman's life is threatened.
Deputy. Dr. Mahony.
First of all, just to address, you're absolutely right, women in Ireland who face the threat of dying during their pregnancy not only require compassion and understanding, but what I would argue is they require good, sound medical treatment, and we must be able to treat them within this jurisdiction, and we must be safe as doctors to do so. But it is always all about appropriate medical treatment based on medical circumstance. In regard to the Medical Council, special procedures are not required to be developed. Generally speaking, in an emergency situation, we're talking about a woman, for example, who might be actively hemorrhaging, who is going to die, who is in the emergency situation that she is dying at that time. Of course, there isn't time to have any sort of protracted negotiation about what is the right thing to do. We simply treat that woman. Hospitals who practice obstetrics have the backup to do that. We always have an obstetrician on call. We have a second obstetrician as a backup. So in the emergency situation where a woman is dying, I believe we have the resources to manage those women, and we do so without hesitation if we are going to save life. In terms of needing clarity, yes, I still contend that as a doctor, an obstetrician practicing in Ireland, I still contend that I need further clarity that I am protected within the law. As I have said several times, the 1861 Offences Against the Persons Act, sections 58 and 59, still stands. The Supreme Court judgment has not been legislated for, although it is over 20 years since that judgment. It itself is open to a degree of interpretation, but it is not supported by legislation. And please be reassured, we are asking for legislation that is broad enough to allow us to do our job, but we also want regulation, and we want this whole process to be monitored. In the Institute submission, which you will hear later, and in all of our opinions, I believe, we accept that we need broad legislation to allow us to do our job, but that this should be regulated in the patient's interest so that society can be reassured that we act appropriately in all times and only to save a mother's life. And it is a part of a proviso of all of the steps put forward that we would monitor terminations of pregnancy that would take place in this country in order to save a life, so we can be very clear. We can be very clear that all decisions to do so are appropriate and according with the wishes of our society, which I believe is to preserve life. And this is what we are about today. It is about saving women's life. It is not about terminating pregnancy per se or destroying babies. It's about saving women's life. Ethos of a hospital. No, we don't practice according to any philosophy, ideology or ethos. Be very reassured. We practice according to clinical demand and according to the clinical situation. It is a science. And you know, finally, what I must say is that it is very difficult for us to assess whether or not or the number of lives we might save in this scenario. We introduce termination of pregnancy, we believe we are saving lives. It's easy in an emergency situation where a woman is actively dying in front of us, but it's the cases that I argue where the risk of life may not be absolutely immediate, where it may be delayed. The woman with cancer, the woman with serious underlying medical disorder, many of these women quietly, and it is my direct experience, these women travel quietly to other jurisdictions where they terminate their pregnancies, and that is a fact. They are among the 4,000 women who travel from this jurisdiction every year to terminate their pregnancies for whatever reason. So I think that it is very difficult for us to assess the negative impact of not having a policy of being able to terminate pregnancy safely when the risk to life might be delayed. And we as doctors need to be able to do that when it is necessary. And I can assure you again, as I keep saying, these circumstances are extremely rare, but they do exist, and doctors are simply looking for the adequate protection to make proper clinical decision to save mothers' lives, nothing else. This is all a very narrow context, a very narrow confine, and be very assured of that.
Thank you. Dr. McCaffrey.
Just to address the issue of the special circumstances and the ethos, I think what the Medical Council were saying this morning was quite clear, that you didn't need a second opinion or a second signatory or a process in place to actually carry out an emergency procedure, because as Rhona says, if someone's bleeding in front of you and her life is at risk, you get on with it and you do that. What
Maybe start. Members can't hear. Sorry, my apologies.
Did anyone hear the first bit?
You might start again, please.
Okay.
Yeah, thanks.
It's to Deputy Mitchell O'Connor's question. I think what the Medical Council said this morning, was my understanding of what they said, was that you didn't need special procedures for emergencies, you didn't need second signatories. What any colleagues I've consulted with, because we are very different in the smaller hospitals. We don't have a second on-call obstetrician. We don't even have a process at this point in time formalised for me to be able to ring a particular master and get a second opinion. What people want is that the legislation will be couched and worded in such a way that we will be protected, that we won't end up in prison because we did something, and that someone decides as a result of an action that we should be reported to the Medical Council. And it is a huge fear among people, because it's an extremely emotive profession to be in obstetrics. With regard to the ethos of hospitals, we practice with clinical guidelines. Clinical guidelines are there for us from our Royal College in London, from our institute and from the HSE. So people practice what's in the best interest of patients on evidence-based medicine.
Dr. Coulter-Smith.
I don't think that I have anything new to add to what's already been said to the answers to those questions. I think there are a substantial number of women who travel to the UK for terminations of pregnancy because of fetal anomalies. That is regrettable that situation exists. But I think this particular discussion is not around that particular area. That may be a discussion for a different day. In terms of emergency interventions, the Medical Council guidelines are there, but our concern is that the law, as it stands, says different. And I think what we're after here is a change in legislation to protect doctors in performing the life-saving tasks that they have to do. The ethos of hospitals, I would entirely agree with what's been said already. We have evidence-based practice in this country. Those guidelines from our own institute and from the Royal College in London. So I don't think that is a huge issue.
We have 7 minutes remaining. There's 3 speakers who've indicated. Deputies Nocton, Dowds and O'Quailon. If you can be very brief, please. Just allow for reply before 20.
Just coming back to Dr. McCaffrey's evidence and her comment that she's just made in relation to medical emergencies. We did question the Medical Council on this this morning, and the Medical Council are of the view that there isn't a need for special procedures to be developed for emergency situations. But that does not mean that there isn't a need for a second signatory. What the impression we got from the Medical Council, and it was hard to get a straight answer from them, but the impression that was clearly given by the Medical Council this morning was that there shouldn't be any differentiation between an emergency and a non-emergency. The same procedures should apply. And in that instance, if a second signatory was required, how would that apply in an emergency situation in a small maternity unit?
Thank you. Deputy Dowds.
I understand if you feel unable to answer the question that I asked, because in a sense it's more of a legal question than a medical question, but if you were willing to hazard an answer, I'd appreciate it. Thank you.
Around 1 minute, please.
Well, just to follow up on the instances, accepting the statistics in relation to a situation where the woman's life was at risk on medical grounds, and the even rarer, and we hope that that is indeed the case, situation where there are suicidal, not only ideation, but suicidal intent. Can you clarify for us your view as to whether or not the rarity, particularly in the latter, is a reason not to legislate, not to regulate? My view would be that where even there is the possibility presenting that there is an onus and responsibility on us as legislators that we should. And just lastly, because it hasn't been referred to in Dr. McCaffrey's submission, and I mean, this is one of the spin-off benefits of this engagement, you highlight the situation at the Coombe Women's Hospital, what you refer to as a well-structured clinic dealing specifically with medical problems in pregnancy. Would you like to offer any other view? Is it that you're commending that particular clinic for replication across the network of maternity sites?
Thank you. We'll start with Dr. McCaffrey.
Okay.
And we've got 5 minutes remaining, so just if you can be concise, please.
I'll deal with Deputy O'Quailon's question first, because he's given me an innings to say what I really wanted to say. I commend the model. If you look at the CMAS report in the UK, which looks at maternal mortality, they make a very clear point, and there was an article in the Lancet journal, I think last year, that there is a real need for a specialty that we call, in the UK they call them obstetric physicians, so they are general physicians with an interest in pregnant women and their illnesses. And that model of care is being rolled out in the UK, and apart from the Coombe, there is no official structure, and I may be corrected, I might be killed by my two colleagues on the right, that there is a need for that kind of specialty. And what I would hope that if we went down the road as legislators and healthcare providers in the future, that we would minimise the need for people getting to the point where they're, in situations that they are faced with now. So yes, I'm commending the model, and I think it is worth, as healthcare providers and for the legislators, to look at in the future. I'm a bit unclear about Deputy Naughton's question.
Yeah, very briefly. The question I have is, the Medical Council have said that there shouldn't be a differentiation in the legal framework regarding emergency and a non-emergency termination. Now, in a smaller unit where you have only one consultant available, maybe out of hours, and there's a requirement for a second sign-off in an emergency situation, how do you deal with that in a smaller unit?
Well, the Medical Council had their opinion, and I understand that there will be other presentations that will have the opinion that you don't need a second signatory, but obviously the legislators and the Minister for Health will finally decide what we will have. If there is legislation and regulation brought in that determines that we need a second signatory, then a process will have to be put in place for the smaller hospitals to allow that to happen. In my opinion, it would be best provided by having a panel of experts or body system or peers that we would be in a position to ring and get that second opinion. And there are systems where you can email, Skype, do all sorts of things, but it will actually have to be looked at, because women will still continue to be delivered in the smaller units, and there is no reason why they can't be.
Okay, Dr. Mahony.
Just very quickly, in the terms of an emergency, this is a pragmatic thing. We must save the woman's life. The woman is dying in front of me. I will not wait for a second signature. I will save her life. That is my job. In terms of suicide, can I just say again, I don't believe we should dismiss suicide as a potential for a woman to take her life during pregnancy. I believe to do so would be judgmental. It would assume that women will lie and fabricate suicide ideation, which offends me. It assumes that psychiatrists in this country are unable to assess suicide ideation, which I believe not to be the case. I do contend, though, that suicide ideation and the real risk that a woman will take her life during pregnancy is extraordinarily rare. It does exist, it's extremely rare, and it must not be confused with general issues surrounding mental health.
Thank you. Dr. Coulter-Smith.
Thank you. I hope that we've demonstrated this morning that there is a requirement for legislation in this area. Life-saving procedures do occur. They don't occur often, but they do occur, and therefore we do procedures that require interruption of pregnancy, and therefore we need legislation, regulation, and protection of our doctors for these procedures. In terms of maternal medicine clinics do exist in other hospitals. They are a fantastic multidisciplinary care setup. They provide best practice care for our patients, and ideally should be rolled out to every maternity unit.
Thank you. Okay, that concludes this session. We now move to non-members of the Oireachtas and of the Health Committee. There are 5 members who've indicated. Deputy Healy-Ames, Deputy Flanagan, Deputy Timmins, Deputy Mahony, Deputy John Paul Phelan. Deputy Healy-Ames, you have 2 minutes.
Thank you very much, Chairman. And
2 minutes, Deputy.
to the witnesses, I'd like to say thank you for your clarity. Dr. O'Mahony, you spoke about the legal uncertainty in very narrow, rare situations where mothers' lives may be saved by a termination. We now have to frame legislation. What should the parameters of this space be, that very narrow, rare situation that you describe? And how might we describe it in legislation, in your view, that would be helpful to the medics? Secondly, you mentioned in interpreting risk, in your view, the mother's view matters and should be taken into account. These hearings are not hearing from any mothers that may have been in this situation here in Ireland or in other jurisdictions where they may have been advised abortions. Do you think their views should form part of these deliberations? I was struck by the fact, Dr. Mahony, that you said we never kill a fetus. Sometimes babies are born alive after abortion procedures in other countries. What do you think would be an appropriate response to this under the proposed legislation? And is there a duty of care in these situations? And finally, if I may, I'm conscious that Dr. Coulter Smith mentioned that you've had 6 terminations to save a woman's life within the last year. And I'm conscious that Senator Crown mentioned this as well, but I'm not clear in the answer. Are you aware of any situations in the Republic of Ireland where medical treatment may have been withheld on the grounds of lack of legal clarity? And is there a possibility that they may not have been reported because of lack of legal clarity in this jurisdiction?
Thank you, Senator. Deputy Flanagan, you have 2 minutes.
I'll just ask Dr. Mahony and our other masters, basically, have you personally ever withheld treatment or refused medical intervention to save a mother's life on legal grounds? Is there any evidence that pregnant women in Irish hospitals do not receive appropriate medical care due to the current state of the law? Do you think that everything possible should and can be done to protect pregnant women from the threat of suicide without terminating their pregnancy? And the next one is a difficult question, but I'm only asking it there, because I think it's critical that legislators, we have all the facts. Just to ask, in relation to the patient who is suicidal, exactly what the procedure is which the pregnancy would be terminated. For instance, if she's 24 weeks pregnant, what exactly would you do? What is done to the baby in this procedure? How is it done? Also to ask, in your opinion, are there any constraints in carrying out abortion in the later stage of pregnancy after 30 weeks before a woman, where a woman presents with a threat of suicide? And just Dr. McCaffrey there in her presentation, she constantly referred to a patient. Does she not believe that there are 2 patients, mother and baby?
Deputy. Deputy Timmins.
Thank you, Chairman. Firstly, for Dr. Coulter Smith, you mentioned that 1 in half a million in Britain, actually, pregnant women commit suicide. Do you have the statistic for the number of pregnant women that present with suicide ideation in Britain? And is that 1 in a half million, for what period? Like, that's over recent years, or how long are those statistics in the public domain? Because it's very difficult to obtain information on it. Secondly, 2 issues for Dr. Mahony. Just for clarification, I note in your speech that you welcome the legislation and regulation. Can you clarify for me, you mentioned about legal protection. Is that as opposed to clarity of procedure that you require the legislation? And do you believe that legislation and regulation can provide greater clarity of procedure than the current medical counselling guidelines? And secondly, have the guidelines, medical counselling guidelines as they presently exist, prevented you from saving the life of a mother in the past? And if so, how? And I note also that you're a member of the executive of the Institute of Obstetricians and Gynaecologists. And has that institute actually sought a change in recent years to those guidelines?
Deputy, we'll take replies to those three speakers and then we'll move on to the next three then, which will be Deputies Mahony, Phelan and Walsh. And we also have Senators Vanabachik and Deputy Tobin as well. Dr. Mahony.
If I can just pick up most importantly, I think it's Deputy Flanagan, 24 weeks. We do not anticipate termination of pregnancy in 24 weeks. Let's be very clear about this. When there is an opportunity to save a baby's life, we will save a baby's life. The threshold of viability in this country at the moment is somewhere around 23 weeks gestation, where we might reasonably expect a chance of survival. And we will offer a baby every opportunity to survive. We will offer a baby neonatal intensive care. So please, let us not ever talk about the ridiculous concept of termination of pregnancy at 24 weeks or 30 weeks. We will deliver a baby at 30 weeks, and the baby has a good chance of survival at 30 weeks. In fact, the baby has over a 90% chance of survival. So let us not confuse this issue. Have I personally withheld treatment? No, I haven't, but that does not mean that I feel legally protected in this country in delivering appropriate medical care in all cases. Again, people ask me, what is the legal uncertainty? 1861 Offences Against the Persons Act remains law in this country. It is binding law. What we have is the judgment of the X case, which allows for the termination of pregnancy in the circumstance of a real and substantial risk to life as distinct from the health of the mother, and that includes the risk of suicide. But that has not been legislated for, that is not supported by legislation, and I can see no reason for not doing so. In terms of legislation, again, I am not a lawyer, but what we are looking for is a relatively broad legislation that will allow us to do our job. We favour broad legislation with regulation because it is very likely or very possible that as medical expertise improves, as there are advances in medical science, we may require at some stage to fine-tune or change legislation regulation. Therefore, legislation should be relatively broad. But I believe, with the fact that the 1861 Offences Against the Person Act can commit a woman and her doctor to prison, making termination of pregnancy in this country a criminal offence, I believe that needs to be addressed, and doctors deserve legal protection in carrying out their job. And I'm going to finish there. Thank you.
I'm not aware of any situation where lack of legal clarity has prevented appropriate care. It certainly hasn't happened in our hospital, and I'm not aware of it happening anywhere else. I personally have never withheld the appropriate treatment for a patient when it was required. I think that in terms of the risk of suicide, I think that all of the appropriate mental health supports need to be made available for women who are at risk of suicide, who threaten suicide or who have suicidal ideation. I think most people would agree, and you can ask the psychiatrist later on, and I think most people will agree that termination of pregnancy is not a treatment for suicide. I don't have the numbers for the UK or for Ireland in terms of the numbers of people who would have suicidal ideation. The 1 in 500,000 pregnancies where suicide has actually happened in the UK comes from their most recent triennial report.
Dr. McCaffrey.
Again, with regard to treatment being withheld because of the law, I'm not aware of, I've never withheld treatment, I'm not aware of it ever happening in my unit, I've never heard of it from a colleague. I think women receive appropriate treatment. With regard to the suicide issue, I feel I've exhausted my very limited expertise on suicide here today, and I think the psychiatrists will probably be very enlightening for you this afternoon. I'm sorry if I offended anybody by mentioning patients and not babies. I thought the word baby came up quite regularly in my presentation. I suppose I was loosely using the term patient as being the person with the illness or the person with the condition, but I reassure you I have used the word baby in my presentation. Thank you.
Thank you. Deputy Mahony.
Thank
Mr. Chairman, just very briefly, could I ask, you mentioned that, all the speakers have mentioned that suicide is rarely used as a reason for termination. Could I ask you, are there mental health issues, or in your opinion, on mothers who lose their babies, or are the baby as a result of losing the baby? In other words, is that very rare as well, or how does it compare? How does it compare with the figures that you for the mothers who might want termination because they're pregnant?
Okay, thank you, Deputy. Deputy John Paul Phelan. Okay, thank you.